Bismillahirrahmanirrahim. So, the topic for today is acute kidney injury. So, this is an extremely important topic because, as we all know, some of the complications of acute kidney injury can actually be life threatening. And as per some studies, actually, this is a very common condition, and almost 7% of all the hospital admissions would get some acute kidney injury during the hospital stay. So it's very important for the junior doctor on the ward to recognize and actively and appropriately manage this condition in the initial settings. So this would be the layout for our talk today. So first we will know how to diagnose the acute kidney injury, and we have to be very clear about what an acute kidney injury is and what is not an acute kidney injury and is just a minor rise in creatinine. So we need, after diagnosing, we first of all need to prioritize to see if there are any red flags for the kidney injuries, because most of these would be life threatening. And then we need to have a look at the drug chart and modify some of the drugs. And then we need to investigate and with some initial investigations, some basic investigations for all acute kidney injuries, and then talk a bit about the initial management and the initial approach to the acute kidney injuries. So the definition is based on international guidelines and they are very clear cut. So there are three definitions, and we can use either of these definitions to diagnose an acute kidney injury. The most common one and the most easiest to use is an increase in serum creatinine by 26.5 micromoles per liter in the past 2 days. Now this increase has to be from what is their baseline. So this is why it's important to know what their creatinine was in the past, specifically what the creatinine was in the past 3 months if it's available, because that's where we would try to see if what their baseline creatinine levels are, and then try to see if they have risen sufficiently enough to be called acute kidney injury. Obviously it's better if we have got more than one readings, because we can be very sure about what their baseline is. The other definition is if the serum creatinine rises by more than 50%, which is known or presumed to have occurred in the past 7 days. And the other one, which is actually a non-clinical one and which can be diagnosed even without a blood test, is if they have got a urine volume of less than 0.5 ml per kg for 6 hours. So for a 75 kilograms average adult, this would roughly be a urine volume of less than around 35 to 40 ml per hour. And if this persists for the 6 hours, then we would say this patient has got an acute kidney injury. So this is a very clear cut and obvious definition for an acute kidney injury, and this should trigger all of what we are going to discuss in our in our discussion now. The other thing is we need to basically stage the AKI. This is important, but you don't need to memorize all of these. The second chart, you don't need to memorize the chart for severity. You can just save this as a baseline, as a resource, and because it's important to classify them to the stage, because obviously the greater the stage, the more severe is the acute kidney injury, and the more urgently that patient may require renal review. So as we discussed, after diagnosing an acute kidney injury, the first thing that we need to make sure is if they've got any red flags. I have divided the red flags into three categories. The first of which would basically highlight if this patient needs urgent dialysis. So things that are included in this are obviously a raised potassium. Any potassium above 6, which is resistant to medical management, is usually an indication for dialysis. And the second thing is if they have got any metabolic acidosis, which basically means a pH of less than 7.25 or a low bicarbonate count. So these are the two most important things that we need to basically identify as soon as we have diagnosed any AKI. The other important things are if they have got any fluid overload, especially if they have got any evidence of pulmonary edema, or if they have got any uremic symptoms, for example, uremic encephalopathy or pericarditis and things like that, or if the AKI is very severe, then this can sometimes be an indication for dialysis. And if they have got any other indication for dialysis, for example, if they have had any toxic dose of a drug which needs to be eliminated via dialysis. So the next category is if this patient needs an urgent urology review or not. This is when we are suspecting any obstructive cause as the cause for AKI, for example, in the form of renal stones or enlarged prostate, which may be due to benign prostatic hyperplasia or due to a cancer of the prostate. The third category is if this patient needs a renal review otherwise apart from requiring dialysis. This is especially important when we are suspecting any intrinsic renal disease as the cause for AKI. So this is a classic ECG example of tall tented T waves of characteristic of hyperkalemia. As you can see, the T waves here are very tall, and as a rule of thumb, the T waves should not be more than 10 millimeters in height in the chest leads and should not be more than 5 millimeters in height in limb leads. Now, after checking for any red flags, we need to move on towards the management. The first and the easiest of which is to have a look at the drug chart, basically to stop any nephrotoxic medications which may be contributing to or which may actually be the sole cause for the AKI, most important of which are ACE inhibitors and ARBs and NSAIDs. Most of the patients who have got pre-renal AKI, for example from hypovolemia, they would require that their diuretics are held as well. For example, if someone has been coming in with diarrhea and vomiting and they develop AKI, then of course if they are hypovolemic, then we need to suspend the diuretics. In some cases, in if for example if some patients have got heart failure and then they develop AKI due to cardiorenal syndromes, then they may actually require continuing of their diuretics, but this has to be discussed with your seniors, especially from cardiology or nephrology teams. But as a rule of thumb, in most of the pre-renal causes of AKI, we would stop the diuretics or at least hold them till the AKI gets better. Of course, we can restart these medications on discharge if we think that the AKI has been dealt with and the cause was other than these medications. The other important thing we need to do is modify the doses, which is of course based on creatinine clearance or EGFR, and we can use BNF or the renal drug database, which is an excellent resource for uh, drug dose modifications as per the EGFR, or we can use Medscape if none of these are available. There are scoring applications which give you which basically give you an easy way to calculate these creatinine clearance or EGFR. You should download those apps. Now, investigation and management. This is of course based on what is causing, what do we think is causing the AKI. As we all remember, AKI is divided into pre-renal, renal or post-renal causes. Pre-renal causes are mainly those that decrease the perfusion to the kidneys, so blood loss, dehydration, or sepsis. And renal is what renal are those mechanisms which damage the renal parenchyma themselves, and post-renal are mostly the ones that would cause obstructive AKI, for example, in the form of a calculi or prostate cancer or enlargement. But these are some of the new initial investigations which a junior doctor should request in most of the cases when they develop when they diagnose an AKI. So if they have got hyperkalemia, which is a potassium of more than 5.5, they should request for an urgent ECG to see for any hyperkalemic changes. Of course, the routine blood tests, full blood count, electrolytes, LFTs, CRP, and blood cultures. CRP and blood cultures, especially so if someone is being suspected of having infections. Electrolytes to check for potassium and sodium counts. LFTs basically to check for albumin because it can be low in some conditions like nephrotic syndrome. Urine analysis is very important in all AKIs because this would give us a clue if the cause is renal or not. Because if we see lots of lots of blood in the urine count, then this can signify hematuria, which would point towards renal disease. Again, or if we see lots of protein in the urine dipstick, then this would again point towards renal renal cause. Microscopy and culture is for if we are suspecting a urinary tract infection or a to be the cause for AKI. Now, ultrasound KUB, we don't need to request it in all the cases, but if, of course, we are suspecting it to be a cause of post-renal AKI, then we would request that. And of course, what we are looking for is mainly if there is hydronephrosis present or not. Hydronephrosis basically means the abnormal dilatation of these structures because of an obstruction downstream. Chest X-ray if fluid overload and pulmonary edema is suspected. Now, if we are sure that this patient is going to go for dialysis, then we should, while requesting for renal reviews, we should request these serologies beforehand, so that because they would be, of course, required pre-dialysis as a screen. Management, of course, is based on the suspected cause. First of all, we need to keep a close eye on their observations, and fluid input and output monitoring should be done, for which a catheter may be required. Because again, if the patient is not producing any urine output, this again can be an indication for dialysis. If the hypovolemia is present, which is in most of the cases, then IV fluids should be given to optimize that, and we should monitor the creatinine and electrolytes as well. We may need to repeat the potassium counts serially. For example, if the potassium is going in the upwards trend, then it's wise to monitor it more frequently, for example every 12 hourly or so. So we need to get an urgent senior review. So as junior doctor on the ward, you need to remember that this all of what we have discussed is just the initial management of what we should do as the house officers or the F1s on the ward. If we suspect that there is no improvement, or if there are or if there are red flags present, or if the cause is unclear, then we should request for an urgent senior review, because AKI, as we said, can lead to even fatal consequences. Summarize, we need to identify the AKI accurately, and this can be diagnosed with one of these three definitions. If there is a creatinine rise of more than 26.4 micromoles per liter in the past 48 hours, or if the creatinine has risen by more than 50% in the past 7 days, or if the urine output is less than 0.5 ml per kg per hour for 6 hours, then we would say the patient has had an AKI. After this, we need to jump quickly to see if they've got any red flags, which are in the form of resistant hyperkalemia or metabolic acidosis. Other red flags include fluid overload, especially if it's in the form of pulmonary edema, and severe AKI, or the presence of uremia, which can be highlighted, for example, by the presence of uremic encephalopathy. After this, we need to move on to the management, and we can have a look at the drug chart to stop any nephrotoxics which may be contributing to or may actually be just the sole cause for the AKI. Examples include ACE inhibitors and ARBs, and we need to modify doses of all the renally excreted medications which the patient is having based on their current EGFR or creatinine clearance, and this can easily be done using a BNF, Medscape, or a renal drug database. Finally, we need to investigate and do the initial management. This, of course, would depend on if the patient has got pre-renal, renal, or post-renal cause. But we need to have take a history and exam to see if the patient gives us any clues for the cause for the AKI. We need to especially look at what their fluid status is, and we need to give them fluids to correct the hypovolemia, and we need to request the initial management blood tests and the urine tests and an ECG if the potassium is high. We also need to request a chest x-ray if we suspect pulmonary edema. If the AKI does not show any improvement, then or if the cause is unclear, or if the red flags are present, this should be escalated to your seniors urgently. So these were the resources used in this discussion. If you got any questions or any recommendations, please let me know in the comments below.